Well, in review on Patricia, what looked like a very easy case had pitfalls. Had we not done a CT scan, we would not have been able to identify the significant buccal undercut on the upper and the undercut on the lower, which would have possibly made our case much more stressful. We identified those, and in fact, had we not had the stent, we would have, where the undercut was, we probably had 3/4 of a millimeter on each side of the implant. And unless you're extremely lucky or very, very talented, the chances of going in there and doing that without a guide of some sort would be something that you wouldn't do on a routine basis consistently. We're going to see Patricia tomorrow. We've relieved the buccal area on the upper denture because in placing these implants, as you saw, I didn't seat them all at once. I placed them and I went back one to the next, and came back and continued driving the implants in. In doing so, we expanded the buccal plate in the undercut area approximately 1 millimeter and probably 1/2 millimeter on the occlusal surface, or the occlusal area of the osseous interface. And keeping in mind, if we had if we don't relieve that area, that will possibly be a source of non-integration. So we're very intent on getting all pressure off of the denture in the buccal undercut area. On the lower, we picked it up with 2 ERA white males, or our retention mechanism. We then went back and relined over our primary implants, which had their metal housings in place. Once the soft liner set, then we removed the metal housings on the primary implants and replaced it with the black male without the housing, which now we have established a passive area or a relief area, so those implants are no longer under function. And the last and probably the most important part of this whole situation to create predictability is to make sure that the occlusion is such that when the patient goes side to side, we're not going to be torquing these dentures, because at this point, it's not the vertical forces that will cause non-integration, it's the lateral forces placed on these implants during healing. And on the upper, you notice that we did not place the angle correction. We didn't place the angle correction because we will most probably see the tissue grow over the top of those implants, and they will be, or that tissue will be our litmus test to see if we're having pressure placed in the area. What would that mean a month down the road? If Patricia comes in a sore spot over one of these areas, that would let us know that the denture is putting sufficient force on the tissue to allow it to be pinched by the implant. And so it's not a subjective thing. Patricia will know, I need to get in right now to have this adjusted. After we make 1.5 to 2 months, we're pretty much in the clear. However, I will probably suggest that we leave the upper implants in at least 4 months before we try to come back and load. So in that case, we would do both the upper and lower in about 4 months. We'll see Patricia tomorrow. She'll be on a soft diet tonight, and she will go home with her dentures in her mouth because we've stabilized them, so I'm confident that they will remain in that position until tomorrow, so that if there is any swelling, we'll be able to seat these dentures back properly for her.